Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Dr. Jane Liebschutz on treating pain in people who use substances. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please place all questions in the Q&A function in Zoom. And now I'd like to give a quick introduction to our speaker today. Dr. Liebschutz is a primary care and addiction medicine physician, substance use researcher, educator, and administrator. She is chief of the Division of General Internal Medicine at the University of Pittsburgh School of Medicine and UPMC. Her clinical and research agenda focuses on prevention and treatment of opioid use disorder, including safe opioid prescribing and disseminating treatments of opioid use disorder in non-specialty medical settings. She advocates for harm reduction and is passionate about physician wellness. And with that, I will hand it off to Dr. Liebschutz. Thank you all for being here today.
Thank you so much, Bethany. I'm going to share my slides. So I'm going to talk today about treating pain in people who use substances. And I'm going to have two cases, and these are actual cases. The name and a few details have been changed for identification, but actually the clinical piece is all accurate. So the first case is Nathan B. At age 19, he had a gang-related gunshot to his spine, and he's paraplegic from the waist down as a result of that. In his early 20s, he began using heroin to help with pains from the injuries. And in his mid-20s, he developed decubitus ulcers from sitting in the wheelchair, which is common in individuals with paraplegia. And he began sniffing heroin daily to help with pain from the ulcers. All right, so that's just the introduction. I just want to say what the learning objectives are for our talk today. So I'd like to describe a framework for acute pain management in the context of substance use disorder, particularly opioid use disorder. Utilize treatment approaches, including multimodal treatment to manage chronic pain in patients with co-occurring pain and substance use disorder. Think about non-opioid medications. Actually, I'm not spending that much time on that, but other kind of pharmacological approaches that can be helpful at managing chronic pain. And then think about safeguards needed for when we do prescribe opioid analgesia in patients with substance use disorder. So when we think about pain and substance use disorder, there is a lot of common overlap. I'm not going to talk about the epidemiology today, just to kind of focus on some of the more clinical relevant pieces. But individuals who use substances have increased vulnerability on the impact of the experience of pain. So what might be going on? They may have depression and anxiety, which amplifies pain. They may have social stress, which can also amplify pain. Because of use of opioids, their pain threshold may be lower than somebody who's never used opioids. Their coping skills may be, and I'll talk a little bit more about this in a minute, the coping skills may be diminished because they've used substances to cope with stress and other things rather than other ways to manage pain. And then they may have financial strain, which limits their ability to take advantage of different treatments for them. Other things that may be complicating pain treatment is if there's ongoing drug use, and I'll talk about that in a little bit, which is pain is a sign of withdrawal. And so you've got a kind of negative cycle about pain. If people have liver disease, that can complicate what options are available for non-opioid pain medication. If there's co-occurring other substance use, and then there's relatively few evidence-based treatments in pain with opioid use disorder. And I will talk about what evidence we do have a little bit later in the talk. All right, so this is a conceptual model. I suspect the figure is a little bit hard to read, but I'll walk you through it. And it's called the canoe model, catastrophizing anxiety, negative urgency, and expectancy. So what you have is you have on the left, this red box is the experience of pain. And then that can lead directly to substance use because you expect that the substance, particularly opioids, will reduce your pain. And that is what opioids do. They have analgesia. So pain can trigger substance use directly. It can also trigger a negative affect, things like anxiety, depression, frustration, anger. Um, and that comes through pain attitudes, pain catastrophizing, meaning you have a little pain and you're imagining the worst thing possible, or you're thinking you're experiencing that as a very large pain because of the meanings, anxiety around experiencing pain, and fear of pain. So that can lead to some of these negative affects. And then there's this concept of negative urgency, which is the tendency to act impulsively when you experience negative emotions. And again, that is very common in individuals who use substances. And so you've got kind of this negative, this pain and how it leads to substance use. And then there's non-modifiable biological and psychosocial factors that also can sort of lead into these things. And this is sort of what it looks like. You've got pain that you experience distress, which then may lead to craving, then use, then withdrawal, which leads to more pain. So we've got a negative cycle that often occurs in the recovery from substance use disorder, or people when they try to slow down or stop their use. So I'm going to just switch now. So that's kind of the theoretical framework around which I'm thinking about how we care for individuals who are both using substances and having pain. And now I'm going to switch now a little bit to thinking about, like, what is the goal of our care for these individuals? And I created this little pyramid, and I'm not an artist, a graphic artist, so this is kind of how I perceive it. But I look at the bottom four blocks there as like the foundation. When I'm a physician, and these are the absolute things I must do as a physician. And I give this talk regularly to non-specialists who take care of patients in the hospital. And so the first and foremost, humanity, humane care. A lot of individuals, and I guess I'm not going to focus on stigma a lot, but any of us in the field have heard reports from those that we care for, and those of us who maybe have lived experience or have family members, that oftentimes they don't even get humane care. They're treated with really negative, dismissal. All right, so humane care is the very basic of what we have to remind ourselves. That is what people deserve. And then there's standard medical treatment. When somebody comes in with pneumonia or a blood clot or whatever they're coming in, or a surgical issue, we need to give them the same treatment that we give any other person who doesn't have substance use disorder. We want to prevent withdrawal. And if they have acute pain, we want to alleviate that. So those are sort of the absolute must-dos in medical care with individuals with substance use disorder. And if you're in the substance use field, these are the things you want to advocate for your patients and have them advocate for. And then, ideally, then we have discussions on their substance use, and if they and figuring out how to help manage that, or what they want with that, or how to reduce the negative impact in their life, if they're willing to initiate medications for opioid use disorder, and ideally link actively to treatment. So that, in my mind, is where we are with goals of care. Um, and as I mentioned, humane care really is trying to decrease the level of stigma, because stigma will erode confidence that addiction is a valid and treatable condition. It does impact care and treatment decisions. You all know that. And we want to use non-stigmatizing language, of person-first language, person who uses drugs, person who injects drugs. And so let's get back to the case, Nathan. At his hospital admission, he comes in for wounds, these decubitus ulcers and pain. He does not think he has an opioid use disorder. He says if the pain could go away, he doesn't think he would use opioids. And he said, and he doesn't want methadone or Suboxone. He said, it's too hard to get off those medications. I really don't want them. So the clinical question in the hospital, and again, I don't know how many hospital-based providers there are here, but what is the optimal pain medication regimen? Because he's got pain. And so this is where we go to the kind of bottom of the pyramid. Humane care, give them standard treatment, make sure you get withdrawal, acute, managed and acute pain. All right. So these are kind of different options that we have. Methadone, buprenorphine, maybe giving them full agonist opioids, oxycodone, hydromorphone, morphine, or comfort meds, really avoiding opioids. And I can't see your hand, so I don't know what you would pick, but just think in your mind where you would go with this. So remember, what's our goal of care for him? Our goal is to help him with his, these are humanity goals. And if you are giving comfort med only and avoiding opioids, I would suggest that that doesn't even meet the basic criteria for humane care, standard treatment, and prevent withdrawal. Okay, so that would be my thought on that. So I really don't think that is an appropriate response, but you would be absolutely surprised, or maybe you wouldn't be surprised how common that can be in different inpatient hospitalizations. All right, so we've gotten rid of this. So now we've got the other three options: methadone, buprenorphine, or full agonist opioids such as oxycodone, hydromorphone, or morphine. So where might we go, Matt? Let's talk now about the full agonist opioids. And there's kind of two choices there. On the left, top left, you see full agonist opioids with one of the medications for opioid use disorder, methadone or buprenorphine, or full agonist opioids without methadone or buprenorphine. And I'm going to suggest that ideally, we would love to see our patients on either methadone or buprenorphine to help manage withdrawal, maybe begin the conversation about longer-term treatment. But full agonist opioids can be quite appropriate, achieving the bottom part foundation of the pyramid, plus discussing the substance use and initiating it. Full agonist opioids in and of themselves, if that is what the patient is willing to take, is very reasonable to, for that foundational care, humane care, standard treatment, prevent withdrawal, and alleviate acute pain. Because then maybe the patient builds trust, and then you could maybe have those other conversations later. Let me dive into those a little bit more. First, should we be concerned about using those full agonist opioids for pain? And there is quite a bit of evidence that individuals who receive opioid medications in the hospital end up much more likely to be still using them at 90 and 365 days. Likely that is for not opioid naive patients, patients who have an opioid use disorder. Avoiding opioids while inpatient isn't going to impact a problem that developed long ago. And I have a ship there saying that ship has long sailed. So in our patients, I don't think there's any reason to avoid full agonist opioids for acute pain. It's not going to make their treatment worse. It's more likely to improve their pain and trust. So there is a theoretical concern with, and IR stands for immediate release, and SA stands for short-acting opioids. And heroin and fentanyl are in this same category. So you get opioid withdrawal-mediated pain, and I mentioned before that I would talk about this. So, and this is what our folks, who use drugs regularly note, which is there's sort of this comfort zone when they take the heroin or fentanyl or opioid medication. And then when it starts to wear off, we get withdrawal, but pain is often a signal of withdrawal. And so it's sometimes hard to distinguish what is the underlying pain condition versus what is withdrawal. And even if there is an underlying pain condition, withdrawal can exacerbate it. So this is what we really want to avoid, if possible, when we're trying to manage pain. So we really don't want to continue just have short acting. We want something there that prevents that withdrawal. I'm not going to talk about that much detail on methadone, except that to talk about the pharmacokinetics. So you guys all know it's very long half-life for sedation. You know, somebody takes it, it's in their system for quite a while. For somebody who has never taken it, it's much longer than those who are tolerant, or folks who use it for treatment of their drug use disorder. But the analgesia impact of methadone is much shorter than the sedation and withdrawal. And I don't know exactly why in the brain that works that way. But again, if you are treating individuals who are on methadone for at an OTP for their substance use disorder, they may tell you that their pain is actually much improved for the number of hours after they take it. But then at night or evening or whatever, their pain gets worse. And when we're talking about the patient, Nathan B., who's in the hospital, and let's say he would say, or a patient would say they'd be okay with methadone. The problem with methadone is and you all know this if you work in a methadone treatment program, that you really can't get up to a steady state and a high enough dose very quickly. And one of the reasons is, and this is the kind of orangey line, straight line there, is sort of the average kind of steady state, level in your blood. But the pink is when you're first going on it, and you get these valleys and hills. So if you go up way too quickly, you may get very, very high levels that may cause too much sedation. So that is really why we go slowly with the methadone. And if you're treating for opioid use disorder, you don't know at what level is going to be enough for the individual to decrease their cravings and use. So that's another reason to go slowly. But in the acute care hospital situation, you still have to go sort of same level slowly. And what did we remember about the analgesia impact? It's only probably 4 to 8 hours. And so if you give methadone once a day, the pain is there the rest of the day. So that's one of the challenges of acute pain treatment. But let's say you just put them on the full agonist opioids, you don't give methadone, and the primary team taking care of them calls you as the expert and says, we're giving him too much, the dose is too high. So what do I say to them? Well, there's been some observational studies, meaning sort of more anecdote. It's not been studied in kind of a randomized trial, but many of us, including me and my team around the country, are now using short-acting agonist treatment for hospitalized patients. And this is scheduled oxycodone or hydromorphone every 4 hours, with occasional IV hydromorphone as needed. And a colleague at University of Pennsylvania looked at 23 cases who were treated with this and compared them with their prior admissions. And among these patients, these individuals had fewer patient-directed discharges, also sometimes called against medical advice, AMA. Their lengths of stays were longer, which is actually better so they could get their treatment. More of those patients ended up receiving MOUD. None of them had falls. One patient did need a naloxone reversal, but that's because they had unsanctioned opioid use that they brought in from out, or somebody gave them from outside the hospital. So this is sort of increasingly done. And so what I would say to the team, and you guys, again, you guys are experts, you know this, if the patient is wide awake and in pain, you're not giving them too much, because the downside of opioids is sedation. And so I suggest the teams don't worry about the number, but adjust the dose to the level of alertness and the level of pain, not the number of the dose. The one caution is sometimes patients have multiple sedating medications, and so if they get them all at once, they can kind of become too sedated. And the same reason we give, 180, 200 milligrams of methadone a day to individuals. We don't go by their sedate. We don't go by the number. We go by the treatment goals. All right. So back to the patient. He said, I'm not going to try methadone, but maybe I'll try buprenorphine naloxone. again, you guys know this. So buprenorphine, unlike methadone, is a partial agonist, and its half-life is relatively long. It stays in your body, 1 to 3 or 4 days, and it comes in multiple forms. The problem, again, you all know this, it can precipitate withdrawal. And just for people who may need a refresher of why it precipitates withdrawal, so what you see in this picture here is these orange kind of these orange shapes are sitting in the brain receptor, and the patient is experiencing the full effect of the fentanyl or the fentanyl. And these little blue things out in the periphery are the buprenorphine molecules. Now, the buprenorphine has a very high affinity for the molecules, for the receptors in the brain where the fentanyl is sitting. So when you get the buprenorphine to come in and at high levels, it bumps off all of those fentanyl, and it's a rapid effect. And what you experience 20 minutes later is precipitated withdrawal. Okay, so that's kind of, sort of what happens. But when we think about doing low dose, avoiding precipitating withdrawal with low dose buprenorphine, this is kind of what happens. You've got the full agonist opioid. Maybe we're going down a little in the dose, maybe not. But what you do is you introduce a low number of buprenorphine over the first couple of days, so it starts to kind of get on those brain receptors, and then and so it's like a slow effect. And then on the fourth day, you fully get that buprenorphine up so that the fentanyl or the other opioid is kind of less in the system, and you avoid precipitated withdrawal. This was published, again, one of these anecdotal, this is the practices. And what we do in my hospitals, we put people on a patch. It's the Butrans patch. Some people do it IV. Some people do the other buprenorphine that's made for pain, very, very low doses. And then you keep that on for 48 hours, and then you give the 2 milligram buprenorphine as a test dose, and you slowly bring that up over the next few days until the fourth day when you're fully qualified. Now, the idea here is that you would then go off the other opioids, but in practice, we continue the pain medications, if there's a painful condition, and that's more and more practice. All right. So he goes on to Suboxone. I take him on as a patient at that point, because that's when I got introduced to him. But even for the couple of years that he was on Suboxone, he was taking it, but he would continue to use heroin. He always sniffed, he never injected, especially at night, because he said that his pain was bad. And he eventually decided that Suboxone wasn't offering him any benefit, and he stopped it altogether. And he began to cycle in and out of the hospital for worsening wound infections. And during the hospitalization, we convinced him to try methadone, and on top of it would give him oxycodone for pain management. And he got very comfortable. And then when he was discharged from the hospital, he was referred to methadone programs, and he would go there, but he would always complain that his pain was not controlled, and he would do okay. I should say, which I didn't put in this slide, but just having known him well, he also had very severe PTSD related to his injury, and death of other members of the his people he hung out with, and fear of future retaliation, things like that. So he had a lot of PTSD. So I tried to give him treatment for that, and he actually did okay with decreasing the PTSD symptoms, but his pain was never controlled. He continued to use heroin and fentanyl. We tried split dose methadone, thinking of the analgesic impact, and that didn't seem to stop the use of the heroin. His function continued to worsen. His self-care was terrible. He was supposed to be changing his wound dressings every day, wasn't doing that. And his mom called me, and they brought him in. His parents are very loving and involved, and he was going to be evicted because his apartment, smells were coming from his apartment. It was so bad. So his family intervened. And when he came to see me, I mean, he smelled horrible. He smelled, like the folks you avoid, kind of on the street when walking by, because there's, the smell is terrible. I mean, I'm assuming a lot of people on this call don't avoid them, but you know what I mean. His hair was matted. His wounds were much, much worse. And he really wanted pain treatment. And so what I did was I made an agreement with him that I would prescribe oxycodone for his pain if he enrolled in a methadone program, because I didn't feel comfortable giving just the oxycodone, because he needed that underlying stuff. And I would see him weekly. I would give him weekly prescriptions, and we would each week make a behavioral goal. And the first week it was to take a shower. And the second week it was to take a shower. And he did both those weeks. The third week it was to, get his house cleaned up a little bit. Then it was to kind of try to get his hair cut and braided, because, just things that these are goals he wanted. These aren't things I decided, but these are things he wanted. And we started to achieve those. Unfortunately, the wounds got very worse. He ended up in the hospital. And he had a 3-month admission to a multi-month admission to the hospital. He's now in a nursing home getting wound changes, but he's on methadone, he's on oxycodone. He's, more stable emotionally, mentally. And if we are able to get him out the nursing home, I will continue this program with him. But, I think he would be dead right now if we hadn't done something like that. So harm reduction moving forward. I'm going to switch gears now. So if you have questions about it or him or, anything about acute care, acute pain, sort of let me know. And I'm going to switch to an outpatient who I took care of for many, many years. His initials are WM, and 72 years old, although I took care of him for, 20 years or more. This guy has multiple serious medical conditions: diabetes, hypertension, COPD, coronary artery disease, gout, hepatitis C, cirrhosis, very complex pain history, chronic low back pain, herniated disc, spinal stenosis, knee osteoarthritis, neuropathy. His substance use history: long-term smoker, history of injection drug use with heroin, but last used 20 years ago. Cocaine, crack use also stopped 20 years ago. Heavy alcohol use stopped use 20 years ago. He goes to AA 3 to 5 times a week. When I see him, his pain is 10 out of 10. He's disabled, very difficult to function. He has moderate depression, relationship issues. He has positives, or he does have a whole group of close family and friends, and he's really very solid in the AA community. And so the question is, what are the goals for this guy? Are we going to be able to get rid of the pain? And I really love this diagram because I think it really captures what multidimensional care is needed for chronic pain. And when you have individuals in front of you, and maybe some of this folks on the call are experiencing this, that like people focus on the pain reduction and the opioids, but there's a lot more to think about besides pain. So if you look at like 12 o'clock, restoring function. I mean, we may or may not be able to get rid of the pain, but we may try to figure out ways to restore function. On around 9 o'clock, you see cultivate well-being. I mean, isn't that the goal for how we care for people, that they have a sense of well-being and improve their quality of life on the bottom? So I think when we think about pain treatment, particularly chronic pain treatment, we want to think about these other goals besides just the pain. And sometimes we really can't touch the pain, but if we can cultivate well-being and improve quality of life, we have really helped the patient a lot. And then there's a whole bunch of different modalities. On the bottom left, medication, of course, is one, but you see it's only one of a number of medications. There are physical modalities, exercise, and I'll talk a little bit about some of these. Exercise is really, really important for pain and function. And then psychobehavioral, again, I don't know if there are therapists on this call, but like And I'll talk a little bit more about some of those, but meditation, mindfulness, some of these other things. And then, of course, there are procedures. Generally, those are one-time procedures and may generally people by the time, they have this chronic pain, they've tried a lot of these. So thinking about what are goals of care for somebody like this, it's really, we want to work with the patient about realistic expectations. And again, I think this is part and parcel when we treat individuals with substance use. We want to think like, what are the expectations? What's reasonable for you to achieve? And then the goal is to sit with them over time and have incremental care. So sometimes even if 10% improvement in a symptom or an experience may actually be a huge impact on quality of life. And we never want to forget multimodal treatment. And I will talk a little bit about what these are. All right, so what's the state of the data? I think for individuals with co-occurring substance use disorder and chronic pain, there's relatively few treatments and programs tested and available. A lot of studies exclude people with substance use disorder. 5 years ago, I would have had almost nothing to present to you. Today, I have some things to talk about. All right, so what are the pillars of treatment for 5 pillars of treatment for individuals with pain and substance use disorder? So, and I'll talk about each of these in more detail in a minute. So psychosocial engagement, physical mobility, weight loss, substance use treatment, and medications. All right, so let's first talk about psychosocial engagement. So there are really a few different studies that have looked at different treatments. So cognitive behavioral therapy, and I'll talk more about that on the next slide. Mindfulness, I'll talk a little bit more about that. And then 2 others really are case management and socialization, which have been shown to improve pain. They haven't been tested in individuals with substance use disorder, but you could imagine that this is a group who would benefit from those. In terms of cognitive behavioral therapy, so CBT is a kind of treatment which is structured, and patients have to do kind of work on, sort of figuring out how their mind is and what their behaviors are. And so it definitely shows that it definitely improves pain, improves pain-related disability, it improves mood, and it decreases pain catastrophizing. And so this was a meta-analysis. It was done quite a few years ago, but I think they still stand. And of course, none of these studies included people with active substance use. There was a publication recently where that was conducted at a residential substance use treatment facility with 500 participants, half of whom were female. And what it consisted was with 8 one-hour group session combining principles of CBT and another treatment called acceptance-based approach to cope with pain and decrease substance use. And what I will show you here on this slide, and it may be a little bit hard to see, but I'll kind of walk you through it, was they did the analyses separately in men and women. So the column on the left is men and the column on the right is women. The 3 charts are similar. So the first one was pain intensity, the second one was pain functioning, and the third one was pain tolerance. And what was the comparison? The comparison was a supportive group. So what do we know is that the only, and the impact, this special CBT focus was the kind of yellow, and the standard psychoeducational group was the kind of darker color there. And what you see is they're almost exactly the same, except in 2 areas. One was the pain functioning in women, which is the middle graph on the right side, showed significant improvement in the CBT group, and the pain tolerance in men showed significant improvement in the CBT group. So you've got some gender differences, and looks like potentially pain intensity also decreased in the women group, but the other ones were really not different. Again, a longer treatment, maybe done in a different setting, it's hard to know. Results were similar, but kind of not quite as robust in the 6-month time period after treatment. So the next thing I want to just bring up is mindfulness. And this was a wonderful study by Eric Garland, who's at University of Utah, that was published a couple years ago. And what they did was mindfulness-oriented recovery enhancement for co-occurring opioid misuse and chronic pain. So this was individuals who were in primary care settings and in Utah, and there were about 250 participants. 2/3 were women, and mean age of 52, and half got this mindfulness-oriented recovery enhancement, and the other half got a supported group psychotherapy, which already is more than they might have. And then they looked at the primary outcome, and what they found was that both pain and opioid misuse was decreased significantly through 9 months compared to the supportive group therapy, with an odds ratio of 2. So that is pretty significant. And so I would say that triggering a behavioral therapy in individuals with chronic pain and opioid use disorder, opioid misuse. And then I'm just going to focus. There's three different physical mobility and functioning. So physical therapy, there's something called psychologically informed physical therapy, which is slightly different than the standard physical therapy. And its core philosophy is really to integrate beliefs, attitudes, and emotional responses into the biophysical patient management. And a primary goal is really prevention of disability, which is different than standard PT, which is to reduce symptoms. I love PT. Nothing's wrong with PT. I think psychological PT is quite interesting. Yoga is, there's been a number of studies on yoga for combined substance use and pain, but mostly they're really low quality studies, very small size, few outcomes. They suggest that yoga improves pain and quality of life. And then pilot studies of randomized trial are showing feasibility of yoga in combination with medication for opioid use disorder. And I bet if I give you this talk 3 or 4 years from now, we'll have more data on this. But certainly that's something to recommend to individuals. And then acupuncture is a third modality, which I really, really like. So this was one of my very favorite studies of all times. It's about 15 years old, but it's a great study. And what they did was they had 4 groups. One group was usual care, and that's the group you see in the dashed red line. And then they had 3 acupuncture groups. One group in the yellow was this very individual to acupuncture. You had an acupuncture expert who would go and figure out, do the standardized, would do the, analysis of the patient based on Chinese, medicine principles, and would do an individualized program. The standardized acupuncture was a program where all of them followed the same points that they would put in. And then the blue line is simulated acupuncture. So this is the same acupuncturist, but they would just stick needles anywhere, not related to the meridians or the grid. And what do you see here? You see that all 3 acupuncture groups performed almost exactly the same, and they were all better than usual care. So what does that mean? Does that mean, gosh, who cares, just sticking needles in, or a standardized acupuncture individual, like they don't really matter? But no, in my mind, there is something about acupuncture, and it is something about these acupuncture specialists that really do improve patients. I don't know what it is, but it seems maybe there's something about the needles going in. I don't know, but they all seem to have some benefit. And so there's no harm really in referring patients to this. And weight loss. Weight loss is, for those who are obese, weight loss can be really helpful because systematic inflammation accompanies obesity and can perpetuate chronic pain. And weight loss alone, in and of itself, can improve pain symptoms and function for individuals who have obesity. No studies have been done in individuals with substance use disorder, but I still think that that's an important piece. Medications, I really didn't want to take up a lot of time going over a ton of medications, but I will say a little bit about opioids, because I'm going to talk a little bit about whether you might consider prescribing opioids to somebody with substance use disorder. So what we know is that opioids for chronic pain, less than half of individuals who take opioids for chronic pain experience 50% or better pain relief. So it's probably helpful for some people, and for other people, it may not at all be helpful, and it may be mildly helpful for some individuals. So it's not a panacea. It's not the goal. There are a lot of other things that are more effective. But when our patients ask for opioids, we have to remember that they may or may not be helpful for chronic pain. All right. So my case, WM, we referred him to acupuncture, CBT, physical therapies, continuing his AANA meetings, but he asked me for medicines. So I just want to think about the risks of opioids. And he is somebody who has liver disease, so a lot of them, like the ibuprofen, the nonsteroidals, would not be appropriate for him. And he can only take so much acetaminophen, and there are other kind of treatments that are contraindication in liver disease. But let's say, what are the risks of opioids in him? So addiction clearly is a risk. Folks with history of tobacco dependence are higher risk for developing opioid misuse. Other addictions, and this is a guy who had heroin injection before. So really kind of concerned about loss of control, even after 2 decades in recovery. And then, of course, the liver disease, he may have encephalopathy. And so we need to avoid any sustained release opioids. What are the principles of safe opioid prescribing? Start low, go slow, short acting, not long acting. Make sure you check the prescription drug monitoring program, do a controlled substance policy, agreement, and then close monitoring. And so this is a question, I know I can't see your hands, but just curious what you think. So when prescribing opioids for pain in a patient with a history of substance use disorder and cirrhosis, which dose of opioids has been shown to be safe? And you can see those choices on there. And the morphine milligram equivalent is sort of shown. These cut points, 200, 150, have been shown to be associated with increased risk of overdose in the general population. So I would just say no dose has been shown to be safe. No one studied it. And particularly no dose has been shown to be safe in liver disease. And so, but it's not like they're not necessarily, but we just don't have the data. So if we're considering prescribing for somebody like this, we need to take into account monitoring. So clearly one is the prescription drug monitoring program. It's associated with lower overdose deaths in the states, like before and after implementation. It's really unclear if it would decrease misuse. However, it does identify doctor shoppers and let you know about your patients that are taking it. What we know is controlled substance agreements are really a policy, explanation of a policy to patient, but they're really not a contract. And that's also not been shown in evidence to be useful or not, but we all do it anyway. And then urine drug screens really test for the presence of prescribed meds and illicit or non-prescribed meds in the past 24 to 72-hour time frame, depending on the medication. And then pill counts, which I personally think are the most useful thing to determine how a patient takes the medications. So when you have somebody like my patient, WM, what are kind of precautions to take when you're considering prescribing opioid use disorder? Well, certainly first choice could be something like buprenorphine, or even working with a methadone program to do split dose. Some programs will give you take homes to, you get your first in person, they give you a small amount to use later in the day because of the half-life, although that isn't very common. So, may or may not be that common. Another option is like with the patient I presented at the beginning, where I was giving him 1 week supply of the oxycodone so that he wouldn't take it all at once and potentially overdose. And then the other one, really thinking about drug screen and pill count every visit. And again, that's the deal I made with my patient, Nathan B., who I presented at the beginning. But so these are ways, if you really have somebody for whom really would benefit them, this would be something to think about to do. And then, of course, the patient needs to continue to address addiction issues, and we need to think about pain that might be associated with relapse and increased use. So that is kind of the end of my formal talk. And I'm good for questions in a second. So just to remind us, we talked about this framework for acute pain management in the context of substance use disorder, thinking about that humane care, the basic care, and then, sort of the ideal would be addressing the substance use in an acute pain situation. But for the most part, we just need to make sure we at least check the boxes for foundational care. We want to think about multimodal treatments for chronic pain, in patients who have co-occurring chronic pain and substance use, and then employ non-opioid medications and non-pharmacological treatments, and then look at safeguards when we do need to prescribe opioids in patients with substance use. So that is the end of my talk. Are there any questions in question and answer? So legal issues around prescribing opiates in the setting of OUD. So I think that the key here is really careful documentation, where you really say, I'm prescribing this for pain, and these are, and then doing very, very careful assessments. Like we can talk at length about urine drug screens, because I know there's a movement towards doing less overall, and I can see all the reasons for it. In this situation, I think urine drug screens are really important because you want to make sure they're taking the medication you're giving them, and you want to think about I almost think it's like contingency management in a way, particularly this first patient I mentioned, where he had to do these behavioral treatments. He had to show up for me to continue prescribing, because it was sort of a way for me to help change behavior. So I think documentation is really, really, really key. And I would be careful about the doses that you're prescribing and the quantity that you're prescribing. But I think if you document it, you have these conversations, and you do those safeguards, I think you are, certainly you're not going to be prosecuted for it. But if there's, if somebody comes and looks, the DA comes and looks at your practice, that will help you. All right.
Thank you, Gus, for your question. Dr. Mock has a question or a comment that a couple of her most difficult MOUD patients had chronic pain and were so challenging to her because they did not agree that they had OUD. Any comments on persistent complex opioid dependence?
So I would say, that's a really great question. And the patient WM, who I presented second, actually got into some issues, which I didn't present about. I did give him opioids, and he ended up kind of using them up quicker than prescribed. And he was interesting because he said he had a opioid use disorder from heroin, but not from his pills. So I still had to do an intervention with him and do this very short prescribing. I think you can agree to disagree with individuals, and they don't have to be labeled, but you can just say, I don't think this treatment is really working for you. You're using more than expected. It's not really helping your pain. I think we could try buprenorphine. And I actually have a patient in my practice right now who is on methadone for pain, no history of, no illicit opioid use disorder, but I just changed him to buprenorphine, and a lot of his digestive symptoms are better. So in any case, I think they don't have to agree that they have it, but you can try to change the therapy anyway. It's a hard one. How can you connect patients with PCPs that are accepting to patients' OTPs? That's a hard one. One of the things that I might look at is talk to your patients who are, if you're an OTP provider or clinician or something, find out from any of your patients if they have a good PCP, and maybe reach out to the PCP and say, we have patients who have, challenges with getting good PCPs, and you seem to be really great for one of our patients. Would you be willing, to see more of them? And maybe, and do you need support around seeing these patients or anything? So I don't think it's really easy. I'm hoping some of the work I'm doing is helping other PCPs accept those patients. But yeah, it's really hard. All right. There's another question about splitting the methadone dose in the hospital setting in the context of pain. So that's a really good question. I do that. I'm an addiction medicine consult program, so we get consulted on these patients, and sometimes we'll do that. The issue is that when they go for discharge, like before they get discharged, you might need to consolidate their dose into one. And then we've had a couple of issues with patients who had endocarditis who needed to be transferred to a skilled nursing facility to complete their IV antibiotic course. And then the skilled nursing facility says, you're doing split methadone, we can't do it. So I think there are some logistical issues, but I do think it can be helpful for pain in individuals in the hospital. Now, if they're on a regular dose of methadone at an OTP and they get admitted for a condition that requires pain, I don't have trouble giving opioids on top of that because the methadone usually just takes up their opioid deficit and prevents craving. But definitely we've done some split dosing, and I think it's very reasonable to try. Is COPD an actual diagnosis? Wait, hold on. Oh, complex persistent opioid dependence, an actual diagnosis. I'm not an expert in that, but I definitely have seen that individuals who have experienced what looks like OUD who are on high dose opioids. And so I think whatever the diagnosis is, I think we can just treat them as if they do and see if that helps. I don't know. I'd love for the other person who asked the other question maybe to comment on it themselves. They have thoughts. Okay, it's not a DSM-5. Okay. Acceptance therapy. So any thoughts of contingency management as part of a plan and money use? So I don't know about contingency management for pain. I'm just going to be pretty clear. There is evidence that contingency management is evidence-based for substance use. It's also for stimulant use, but it's also been shown to be effective in opioid use. And so I don't know about the pain situation about contingency management. So I'm going to just say I don't know whether how that would come into play with the treating pain different from medication for opioid use disorder. It is alternative pain therapies. It is time consuming in the office to convince patients. It really is. This is really hard because everybody believes I think everybody believes that those opioids are the be all and end all for pain, and the alternative therapies are hard. So that may be, that's our job as clinicians to try to convince them to do that. It's also expensive. There are a lot of barriers to those programs, right? Where are they going to find a yoga class that isn't young people in a heated yoga? They have to find, programs that are actually geared towards their needs, and those are hard to find. So I don't have a great solution. There are some online kind of yoga things and getting people to walk, getting people to move is really, really helpful for helping with chronic pain. And some of the other socializations, getting people to therapy. Yeah. I managed to do it over time. It's just persistent relationship building, incremental change, trying one little thing, trying another little thing. So yeah.
I'll take this opportunity to share that if there are any other questions, please place them in chat. We're only going to be answering questions via the chat today. Agreeing with Wendy, thank you so much, Dr. Liebschutz, for this presentation. Now I want to go do some yoga.
I'll do a
yeah,
little yoga right now.
yeah, yes, we can all.
Yeah, just breathe and yeah. All right.
But
good
thank
luck,
you,
and I know
everyone.
you guys are doing fantastic work. And if this at least supports you in the work you're doing, I'm hoping it's helpful for you. Yeah, we're all in this together.
And if there are any other questions, or if something comes to you later, you can always send me an email, and I can pass it on to Dr. Liebschutz, or you can, she shared her email, you can send it to her directly. But thank you so much, everyone, for joining us today, and we'll give you 3 minutes back in your lunch hour. And we hope to see you again soon.